Greetings, ladies and gentlemen. This will be a talk on acute adrenal insufficiency. This is not going to cover the chronic adrenal insufficiency syndromes, such as Addison's syndrome. This is only talking about emergency treatment of acute hypoadrenalism. So acute adrenal insufficiency is also referred to as adrenal crisis. I use those terms interchangeably. This is a life-threatening condition in which the body is acutely deprived of cortisol and oftentimes also aldosterone. Remember that those are both secreted from the adrenal gland, just different parts. This is an endocrinological emergency. This often occurs on surgical wards. It can occur on OB wards, can occur on medical wards. So it's very important that all physicians are aware of what adrenal crisis is. To understand what adrenal crisis is and why it causes the things it does, it's important to understand what cortisol does, since that's the primary chemical that is deprived. So cortisol most importantly stimulates gluconeogenesis, and I'm just going to preface this with saying that cortisol is released during times of stress. And when I say stress, I don't mean, oh, I'm stressing out for that test tomorrow, or I'm stressing out because there's a death in the family, or I'm stressing out because I don't know how I'm going to pay the bills. What I'm talking about is physiological stress. Yes, to some extent, psychological stress is physiological stress, but physiological stress being you're ill, you just had surgery, you just delivered a baby, things like that. So cortisol stimulates gluconeogenesis, which is important because as the body's metabolism is faster, you're going to need more glucose. It downregulates the immune system, which may seem somewhat counterintuitive as far as if you have an infection, but cortisol downregulates the immune system, particularly because there are times of stress where the immune system is overactive, and so that's the theory as to why cortisol downregulates the immune system during stress. It also affects blood pressure, and there are various other effects, but those are the three that are going to be most important in the physiology of adrenal crisis. So who's at risk for adrenal crisis? And I tried to put these sort of in order of when you'll see them on the USMLE, how often, but certainly don't take my word for it. So patients with Addison's disease or who have been diagnosed with any other kind of primary hypoadrenalism in the event of an acute stressor. So like I mentioned, illness, surgery, childbirth, etc. So there are patients where you'll know that they have a history of Addison's disease, or you might not know. Other primary hypoadrenalisms can cause adrenal crisis too in the presence of a stressor. Patients with meningococcemia. So you may not know this. You'd have to look at the history and the physical to know that there's a possibility of meningococcemia. Things that point to meningococcemia would be something like nuchal acute onset, a rash, purpuric rash, sudden withdrawal of exogenous corticosteroids. So this should be in the patient's history that they've been on steroids and then suddenly for some reason they stopped, or they've been on steroids and they're in adrenal crisis, so you can make an assumption that possibly they have stopped if you don't have a history available. Pituitary necrosis often occurs in the presence of pituitary apoplexy, and what pituitary apoplexy is a tumor in the anterior pituitary or posterior pituitary for that matter that remains. A lot of times we don't surgically remove them. We just keep them there because surgical removal, the risks outweigh the benefits. But the risks of having a pituitary tumor is that you can get rupture of vessels into the tumor, and you get dead tissue then. So pituitary necrosis can cause adrenal crisis, and that's generally in the setting of pituitary apoplexy. I talk about pituitary apoplexy in the pituitary lectures. It can happen following bilateral adrenalectomy. So bilateral adrenalectomy is often done for patients who have adrenal cancer or other forms of retractive hyperadrenalism, and so if the surgeon is not administering enough cortisol or steroids in a patient that they've done a bilateral adrenalectomy, then the patient can go into adrenal crisis. And then, interestingly, adrenal crisis can be precipitated simply following the administration of etomidate. And etomidate is a general anesthetic. So, as I mentioned, the history and the physical are going to help you a ton, because a lot of times there's not going to be, a lot of times the physical symptoms, the physical signs are going to be rather nonspecific. When you look at the symptoms of adrenal crisis, they don't really tell you anything. It can just look like general shock. And so the fact that you need to know that this is adrenal crisis and not just regular old shock is important, because in adrenal crisis, you're generally not going to respond to fluids and pressors alone. You're going to need steroids. So having the history and physical is going to help you understand that this is adrenal crisis or possibly adrenal crisis, and so you can take the steps that are appropriate to save the patient's life. So if you know that the patient has Addison's disease or other adrenal insufficiency, a lot of times the disease is going to show up in the patient's history, or they may have signs of Addison's disease, which could include thin build or hyperpigmentation. And a lot of times that hyperpigmentation occurs on the joints and creases. Why do patients with Addison's disease get hyperpigmentation? Well, Addison's disease is a primary hypoadrenalism. So that means that they don't secrete cortisol from their adrenals. Because of that, they have a high ACTH, because their pituitary says, well, we need more cortisol. And so it's secreting ACTH and secreting ACTH, but the adrenals aren't working. And the hormone that is released by the hypothalamus to tell the anterior pituitary to release ACTH is corticotropin-releasing hormone, which not only stimulates ACTH, but it also stimulates melanocyte-stimulating hormone in the pars intermedia. And melanocyte-stimulating hormone works perfectly fine. So what you've got is an excess of melanocyte-stimulating hormone in the presence of Addison's disease that causes hyperpigmentation. And that tends to occur on the joints and creases where there are more melanocytes. So you see it on like the elbows and on the knees and on the palms and so forth. Meningococcemia is another really, really important one, because Neisseria meningitis is a very common disease, and so these patients will tend to have nuchal-rigidity, altered mental status, increased white blood cell count. However, that's not specific to meningococcemia. And then a purpuric rash, and that purpuric rash is very, 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 very characteristic, suspicious of Neisseria meningitis. And in the presence of purpuric rash, you would resort to this being the suspective diagnosis. If it's due to a withdrawal of exogenous steroids, generally that's going to be in the patient's medical history that they've been prescribed exogenous steroids. And so it's important to know if the patient's been prescribed exogenous steroids. If they're taking exogenous steroids, perhaps for Addison's disease, that can be a cause right there. Pituitary necrosis, something that will help you point towards that is that they have a history of pituitary adenoma. Or if the patient is postpartum, they may have Sheehan syndrome, which, remember, is pituitary necrosis due to hemorrhage into the pituitary, and that's postpartum. So if the patient is postpartum, pituitary necrosis secondary to Sheehan syndrome is going to be something to think about. Following bilateral adrenalectomy, of course, that's going to be based on history. And then if it's due to etomidate, that's going to be generally when a patient is intra-op or post-op, having had general anesthesia with etomidate. So what do we do for the patient with adrenal crisis? We already mentioned the history, that various factors can indicate the cause leading to adrenal crisis, such as childbirth, pituitary adenoma, prescribed steroids, and so forth. The symptoms are going to be very nonspecific. They're going to be weakness, abdominal pain, nausea and vomiting, diarrhea, confusion, altered mental status. That sounds exactly what you could have in shock, in sepsis. And so it's important that you know the history and that you have a cortisol level as well on patients, because If you're only giving fluid and pressors to these patients, ultimately they will die. They will not respond to those alone. They will respond for a little while, but they won't respond to those alone. Other things that you can see is a dehydrated appearance. They may have nuchal rigidity and meningeal signs if an infection is the cause. On physical exam, these patients are always going to be hypotensive, and most of the time they're going to be febrile, regardless of whether it's an infectious etiology or not. They may have increased skin pigmentation, or they may have a purpuric rash. Luckily, the most common causes of adrenal crisis are easily diagnosable if you get a good history and physical. Now, your labs, which you should always be drawing your basic labs, and you should be given these on the USMLE. It's not going to be most of the time that the next best step is going to be to get a CMP, because that's too easy. You're always going to be given, you should always have at least your basic lab, CBC, CMP at the very least. So you can see what the electrolytes are doing, where the blood cells are. And in adrenal crisis, you are very often hyponatremic, meaning a sodium of less than 135 milligrams per deciliter. And oftentimes you are also hyperkalemic. A lot of times you're going to have a pre-renal failure picture, so that's going to be an elevated BUN, and it'll be an elevated BUN to creatinine ratio, meaning more than 20-1, and that's due to the dehydration. So what happens in adrenal crisis a lot of times that you don't have sufficient release of aldosterone, and so you go into sodium wasting, and with that you lose water, and so you become dehydrated, and with dehydration comes pre-renal failure. Dehydration and pre-renal failure, severe dehydration and pre-renal failure are practically synonymous. You should always have a cortisol level on patients because a low cortisol level is going to be diagnostic of adrenal crisis for whatever cause. And of course, you should always have blood cultures because there could be an infectious etiology. Those two things, though, however, are not going to come back immediately. Those things will take time. So in any patient that's hypotensive, that shows signs of possible adrenal crisis, and has a possible factors in their history that may predispose to adrenal crisis, you should be immediately giving these patients IV dexamethasone. You have to have a high index of suspicion here, because giving fluids and pressors alone are not going to sufficiently treat the patient. They can die if you don't give them the IV dexamethasone. So if a patient has symptoms, which are the symptoms that I mentioned here, and a history that could predispose to adrenal crisis, or typical labs, meaning hyponatremic and hyperkalemic, and a pre-renal failure picture, that warrants immediate IV dexamethasone bolus, and that's 100 to 300 milligrams given over an hour, and that should be given, of course, along with fluids and or pressors. And you don't want to wait for the results or the underlying cause. You don't need to wait for the cortisol level. You don't need to wait for the blood cultures. You have to keep a high index of suspicion. So symptoms, I wouldn't say just based on these symptoms alone, but symptoms plus a suspicious history, or symptoms plus a suspicious set of labs, should warrant immediate dexamethasone treatment. Now, once you get a low serum cortisol back from the lab, which shouldn't take too long, that's going to be diagnostic of adrenal crisis based on the patient's presentation. And you can continue giving IV dexamethasone or IV hydrocortisone continuously. However, you should also be working up for the underlying cause. And like I said, most of the time it's going to be pretty apparent based on the history and physical. But you're going to need to work the patient up for an underlying cause. So if the patient has a rash, definitely treat them with broad-spectrum antibiotics. I like to use ampicillin and gentamicin until the cultures come back, just because those two drugs together cover practically everything. and of course, you're suspecting Neisseria meningitidis because Neisseria meningitidis, when you have meningococcemia, which is caused by Neisseria meningitidis, that can cause it causes a hemorrhage into the adrenals, which then kills the adrenals. And that's called Waterhouse-Friderichsen syndrome. So this is a specific manifestation of Neisseria meningitidis, and so that's why you're suspecting Neisseria meningitidis. You also would get that purpuric rash. So if a rash is present, go ahead, in addition to the steroids, give ampicillin and gentamicin. A CT scan can be useful to confirm bilateral adrenal hemorrhage in that case. It's also useful to get a chest x-ray because there can be other malignant or infectious causes, fungal causes, cancerous causes, particularly in the lungs, so a chest x-ray can be helpful to rule those things out. And an ACTH administration test will help to see if the cause is due to an adrenal insufficiency. So when you give ACTH, you expect that that's going to increase your cortisol levels. If the problem is in the pituitary, like it would be pituitary apoplexy or Sheehan syndrome, then administering ACTH is, yes, going to increase the cortisol levels because the problem is a low ACTH because you're not getting things out of your pituitary. The adrenals are just fine. So if you get a response, an increase in cortisol levels to ACTH, that indicates that you have a pituitary problem. If you don't get a response to the ACTH, that indicates that you have an adrenal problem, and that points more towards Waterhouse-Friderichsen syndrome due to Neisseria meningitidis, or due to adrenal insufficiency due to Addison's disease. So as far as what we do with these patients, well, of course, while they're in the ER, we're going to be giving them the necessary steroids IV and working them up acutely. All patients with emergent adrenal crisis, which is really any adrenal crisis, should be admitted to the ICU for monitoring of electrolytes and hemodynamic observation. Certainly within the first 24 or 48 hours, they are at risk, so they need to be monitored, have their electrolytes monitored at least every 4 to 6 hours, and have their blood pressure monitored very closely. Fluids should be given as acutely needed. They can be transferred to a general or intermediate ward per protocol. Different hospitals work differently, and as tolerated, they can be switched to PO, corticosteroids, which we would use cortisone. You may need to treat, and this is particularly in the case of patients who have adrenal problems rather than having it be a pituitary problem. They may need mineralocorticoid replacements as well. So cortisone will not replace the mineralocorticoid. Remember, mineralocorticoid is like aldosterone, and we need aldosterone because it's part of one of our primary regulators of blood pressure. So and the reason for that is because if the pituitary is the problem, well, that's just ACTH and cortisol, and that's not as big a deal on the renin-angiotensin-aldosterone system. However, if it's the whole adrenals, then your aldosterone is going to be affected too. So you may need fludrocortisone replacement in addition to cortisone. And that's just going to depend on the labs and on their electrolytes and how their sodium and potassium weighs out as they're in the hospital. Of course, as I mentioned, maintain euvolemic status. That's part of your ABCs. Treat the underlying cause. And the patient can be discharged once the electrolytes are stabilized and you've determined an underlying cause. It's important to educate the patient to consistently take their steroids when they're prescribed steroids. They can't be missing them because if they miss them, they can go into adrenal crisis. And if they're ill or if they feel ill or think that they may be coming down with something, they should double their normal dose and seek medical attention. So they should double their dose until they get medical attention, and a physician can tell them whether they need to continue that or figure out what the illness is. But if they feel ill, they should be doubling their dose and seeking medical attention. And that's all I've got for you.